Hello, my name is Leslie Wooldridge. I'm going to talk to you today about percutaneous tibial nerve stimulation, an effective overactive bladder treatment in the clinic setting. As full disclosure, I am on the speaker board for Astellas Pharmaceuticals and a consultant for Uroplasty Incorporated. I have no other relationships to disclose related to this presentation. This presentation was also supported by an unrestricted educational grant from Uroplasty Incorporated. The objectives for today are: I will present to you an OAB algorithm of care, describe PTNS, discuss PTNS clinical benefits for patients, present recommended documentation, and summarize PTNS efficacy for refractory overactive bladder patients. 16% of U.S. adults have overactive bladder. 60% of those adults do not seek treatment. Of the 40% that do seek treatment, 20% are refractory. As practitioners, we must consider the following with overactive bladder therapies: the fact that 20% are refractory to conservative treatment. Patients want effective alternatives. Patients want non-invasive therapies. Healthcare providers want safe, efficacious therapies. Side effects, efficacy, and cost are important. When working out patients with overactive bladder, history and physical are very important. Documenting urinary symptoms, their onset and duration, other therapies that have been used to address these symptoms, and the patient's coping mechanism are very important. Relative labs, voiding diaries that present important objective data when considering initial treatment and ongoing success are important. It is also critical to rule out urinary tract infection, bladder prolapse, atrophy, and elevated post-void residual. In the algorithm of care for overactive bladder, treatment begins with behavioral interventions, including fluid and diet control and urge reduction techniques. Pelvic floor therapy, including Kegel exercises, biofeedback, and pelvic floor stimulation, also are a consideration. There are multiple medications on the market that are effective. Some patients may not tolerate the side effects or efficacy is lacking. PTNS would be the next step in the algorithm. You may consider dual therapy of medications and PTNS if meds provide some relief, but the patient's therapeutic goals are not being met. Other therapies completing the algorithm include Botox, sacral nerve stimulation, and surgery as a last resort. Indications for percutaneous tibial nerve stimulation include urgency, frequency, daytime and nighttime, urge incontinence, refractory to 2 or more overactive bladder medications, drug side effect intolerance, unable to take drugs orally, or contraindications to anticholinergics. PTNS is peripheral neuromodulation. It is administered via the posterior tibial nerve. It is delivered through a percutaneous needle electrode. The electrical current influences activity along neural pathways. The signal is modulated to and from the bladder via retrograde sacral plexus stimulation from the tibial nerve. The mechanism of action is not entirely understood. Urgent PC neuromodulation system consists of an urgent PC stimulator, an urgent PC lead set, and it is the only FDA-cleared PTNS device on the market. When positioning the patient, it is vitally important that the patient is comfortable, that the leg is slightly elevated, and that the urgent PC stimulator is in a safe place. PTNS is delivered via a 34-gauge needle inserted at a 60-degree angle, 3 finger breaths above the medial malleolus. Impulses travel through the posterior tibial nerve to the sacral nerve plexus. PTNS is a 30-minute in-office treatment. Therapy begins with 12 treatments, typically once a week. Ongoing therapy is tailored to meet patients' individual needs and goals. The advantages of PTNS are that it is minimally invasive therapy, it is delivered in the office setting, it can be delivered independently by a trained nurse practitioner or by a registered nurse or physician assistant under a physician's direction with an order. It is a non-drug, non-surgical therapy. There are rare local adverse effects. Side effects of PTNS versus OAB medications include: with PTNS, they are minor if at all. There might be some transient bleeding at the insertion site and or discomfort at the insertion site. OAB medications, however, side effects include constipation, dry mouth, blurred vision, urinary retention, cognitive disturbances, and QRX complex changes. Contraindications to PTNS are patients that have a pacemaker or implantable defibrillator, patients prone to excessive bleeding, patients with peripheral nerve damage or pregnancy. Overactive bladder medications, contraindications include allergy to the medication, slow gastric emptying, elevated post-void residual, narrow-angle glaucoma, or existing central nervous system problems. PTNS has statistically shown significant changes in voiding symptoms. Over 30 publications have demonstrated safety and efficacy in reduction of urgency, episodes of urge incontinence, reduction of frequency of urination, both daytime and nighttime. There have also been no significant adverse events or side effects reported. In these studies, 60 to 80% of patients have responded positively. In a recent retrospective chart review, of 141 patients, 67% were satisfied with their treatment results. The median week to improvement was 5 weeks for nocturia, 7 weeks for frequency, 6 weeks for urgency, and 6 weeks for urge incontinence. In another review of published literature, medically refractory patients achieved 60 to 80% positive response rate with PTNS. In the ORBIT study, which was PTNS versus tolterodine LA 4 milligrams, there was a 1-to-1 randomization of 100 subjects. Of those subjects, 79.5% considered themselves cured or improved with the PTNS arm versus 54.8% subjects in the drug group during the 12-week study. In terms of objective changes, both groups decreased frequency, urgency, nighttime voids, and increased voided volume. In the SUMMIT study, PTNS versus sham, 220 subjects were randomized 1-to-1. 55% of PTNS subjects and 21% of the sham subjects showed significant improvement in frequency, nocturia, urgency, and urge urinary incontinence. In addition, a recent study showed 71% of patients that were randomized into a PTNS group were responders versus 0 in the placebo group. In the STEP study, which looked at percutaneous tibial nerve stimulation long-term, patients were treated with PTNS for 12 weeks, then followed for 30 months with occasional treatment, sustaining their urinary symptom improvement. There was a continued decrease in urinary incontinent episodes from 3.8 to 0.5. There was also a decrease in urge episodes from 8.6 to 2.5 in a 24-hour period. OABQ results showed significant change in quality of life in 86%. Most notably were changes in sleep patterns. The mean treatments per month were 1.2. As a chronic condition, ongoing therapy for overactive bladder patients is critical, and this shows that one treatment a month may be adequate for our overactive bladder patients to be successful in their outcomes. PTNS can be effective alone or as an adjunct to medications. It has similar symptom improvement as one of the leading OAB medications, tolterodine LA 4 milligrams. There are no serious side effects with PTNS. Overactive bladder is a chronic condition, and as with all chronic diseases, ongoing treatment is necessary. Implications for clinical practice. PTNS expands overactive bladder treatment options. Weekly patient encounters provide additional opportunities to reinforce behavioral interventions. It is an effective option for patients with urgency, frequency, and urge incontinence. It is a non-invasive alternative. It is an ideal addition for any practice treating overactive bladder. When choosing treatment for urgency, frequency, and urge urinary incontinence, you must consider indications, efficacy, patient selection, time, benefits versus risks, cost to the patient, facility, and insurers, outcomes, and follow-up. In preparing your patient for PTNS, it's important to review the treatment, the frequency and length of therapy, including potential need for ongoing therapy. It's important to discuss the expected effects. Up to 60 to 80% improve, but results may vary from patient to patient. The patient needs to set his or her goals along with the practitioner. It's important to talk to the patient about when they may expect changes, which may occur around the 5th to 6th treatment. Potential adverse effects of PTNS might include slight discomfort at the insertion site. Continued commitment to behavioral interventions include Kegel exercises and urge reduction techniques. PTNS is a great opportunity to give ongoing education to these patients during treatment period times. Continuation and weaning of bladder medications may occur around the 5th or 6th treatments. Documentation must include assessment, diagnosis, and previous overactive bladder treatments. Bladder diaries are a validation of patient improvement. They should be completed at baseline, after the 6th treatment, and after the 12th treatment, as well as periodically during ongoing treatment. A treatment log is very helpful in giving the practitioner information that is going to be helpful in comparing weekly treatments and outcomes. In addition, all of this documentation may be necessary for successful payment. PTNS has a unique CPT code 64566. Many private payers cover PTNS, including Aetna, United Healthcare, and other Blues. 10 out of 13 Medicare carriers cover PTNS. Medicare Advantage plans follow local jurisdiction. Document all treatments, including bladder diaries, to maximize your reimbursement. Reimbursement support is available from Uroplasty. You may contact them by email or by telephone. Ensure that your coding and billing staff understand correct coding, the pre-authorization process, and appeals and denials. As a provider, you may have the opportunity to advocate for coverage on behalf of your patients. What is the future of PTNS? It is an addition to a growing arsenal of OAB treatments. Reimbursement promises to improve. Current and past research studies show efficacy with urgency, frequency, and urge incontinence. It can be performed by a variety of healthcare providers, and it allows treatment access for many overactive bladder patients who would otherwise not have effective therapy, who cannot take medications, or have contraindications to medications for overactive bladder. In summary, PTNS is a proven effective therapy for overactive bladder. Patient selection is key. Practitioner technique is very important. Continued behavioral or drug therapies may be used concurrently, but remember to keep expectations for your patients realistic. After seeing success with PTNS in my own practice and how it is life-changing, I encourage all of you to update your algorithm of care and provide PTNS as an effective treatment alternative for patients with OAB. Thank you very much.